Hello, everybody. My name is Nitish Padwar. I'm a cardiologist at the University of California, San Francisco. And I'm going to talk to you guys today about introduction to ECG. Uh, as a cardiologist, my specialization is in looking at the rhythm problems of the heart. So ECG is the thing that started my interest in cardiology, and I hope I can get you guys interested in this. So some of you can take on this as a career and become leading electrocardiographers in your region. My talk is going to focus mainly about, and start from the basic of electrocardiogram, how to record an ECG, and then the different kinds of information that we can get from the ECGs, and how can you interpret the ECG. So this is the first slide. This is Eindhoven, who um, was the first person to record an ECG, and this is how he recorded an electrocardiogram. And as you guys know, most of you should know that he got the Nobel Prize for, he's the father of electrocardiogram. He invented the ECG. When we do an ECG, we have a thing called the Einthoven's triangle, which is the basis of looking at the vectors and the direction of every, the QRS, the Pwaves that we see on an ECG. And so this is a basic thing that everybody should be familiar with. And that is the lead 1, which goes between the left arm and the right arm. Then there is a lead 2, which goes from the left arm to the left foot. And then lead 3, that goes from the right arm to the left foot. So the general rule is lead 2 is equal to 1 plus 3. If you take 1 plus 3, it becomes lead 2. So this is a basic fundamental principle that you should know. And you should understand this is how basic ECG is started and done. So everything else is based on that. So I always keep this image in my head about lead 1, lead 2, and lead 3. And then once I know that, I can derive everything that I see on the ECG based on this. So this is a example of some of the initial ECG recordings that were done. So as you guys know, the ECG consists of the P wave, which represents activation of the upper chambers of the heart or the atrium, followed by conduction through the AV node, and then activation of the lower chamber of the heart, which is the ventricle, which has 3 parts to it, which is called the QRS, the Q, which is the first negative deflection, R wave, which is the first positive deflection, and then S wave is the second negative deflection. Then followed by repolarization of the ventricle, which is called the QT interval. And you always have to have a T wave associated with the QRS, because the T wave means repolarization of the ventricle. Without that, the next repolarization cannot happen. So the basic 3 leads that I showed you were lead 1, 2, and 3. This slide shows you the augmented lead on the ECG. The augmented leads on the ECG are the AVR, AVL, and AVF. And this is how they are derived. So AVR is the right arm, augmented right arm lead, augmented left arm lead, and then the augmented lead in the left foot. This slide will show you vectors of the ECG. So that is the direction in which electrical activation happens in the heart. And this is very important to understand if you're going to be reading ECGs, because you can, by looking at orientation of the QRS and the P waves in different leads, you can derive what the vector is and what is the normal vector and what is happening to if you have disease state in the patient. So the initial activation, you can see with these arrows, this is how the initial QRS activation spreads throughout the ventricle. So you can see activation that is spreading over here. That's how it spreads through the ventricle. And that's how we get the vector of activation. This is the normal. If you have a normal heart, this is how the vector activation works. So the vector loops can be directed more anteriorly, more leftward, more rightward, more inferiorly, more posteriorly, depending on different disease processes that can happen. So this is again same thing. You have a vector activation of the normal activation of the heart, of the ventricles. This is how it goes. If the patient develops left ventricular hypertrophy, the vector is shifted towards the left. If the patient has left bundle branch block, again, the vector is shifted towards the left. If the patient develops right ventricular hypertrophy, the vector loop will be directed towards the right side. If the patient has right bundle branch block, the vector will be activated towards the right side of the heart. Then one of the main uses of the ECG is to diagnose coronary artery disease and myocardial infarction. And so to diagnose that, you again look at the vector loops that develop and you look at the ST wave changes. So if somebody has had anterior myocardial infarction, this is the orientation of the vector loop. So it is directed more towards the left side. Same thing with inferior myocardial infarction. And then if you have a posterior myocardial infarction, you have more rightward activation of the vectors. So as I told you earlier, the three different things that you notice on the ECG are the P wave, the QRS, and the T wave. So if you look at the P wave, the duration of the P wave varies from 0.08 seconds to 0.11 seconds. Usually, if you do an ECG on a 25 millimeter speed, one small box that is recorded on the digitized ECG represents 40 milliseconds. So if you have 5 of those, then that represents about 2 seconds. Okay. So based on that, you can derive the rate of the heart rate that the patient has. So in the limb leads, usually you will have some notching, and it's the P waves are in sinus rhythm are upright in lead 1 and 2. And they should be upright in AVF. There might be some notching that you can notice in V1 and V2. In the limb leads, the amplitude is less than 2.5 small boxes. And on the precordial leads, it would be less than 1.5 millimeters. So the time that it takes to go from the P wave to the QRS is the PR interval on the ECG, which represents conduction through the atrium and through the AV node. The usual duration for that is 0.12 to 0.2 seconds. And that is usually referred to as the PR interval. If it is shorter than that, 0.12, then one has to think about some other abnormal ways of conduction. The most likely scenario is what we call as Wolff-Parkinson-White syndrome, where patients have another way of conducting to the ventricle that bypasses the AV node. If it is longer than 0.2 milliseconds, then we refer it to as prolonged PR interval, and I'll show you different examples of that, different conditions that cause that. The PR segment is the segment from the P wave to the R wave. It's usually flat, but if it is more than 0.5 millimeters, then we call it PR elevation. If it is less than 0.8 millimeters, then we call it PR depression. And this has implications in terms of looking at uh, damage to the atria. So PR elevation would be seen in conditions like where you have small infarction of the atrium. PR depression is usually seen in patients who have conditions like pericarditis. These are again showing you the QRS complexes with the different leads. So the AVL, AVR, lead 2, AVF, this is the normal direction of the QRS vector in these patients, in normal patients. So you can see normal patient, lead 1 is positive, 2 is positive, 3 can be biphasic. AVR is always negative because the AVR is on the right shoulder and most of the QRS complex is going away from AVR. It is usually going towards AVL, so the AVL is also positive, but it is not as positive as lead 1 and 2. And then AVF is also positive. Now, very important thing before you start using the ECG to make any kind of diagnosis is to make sure that the person doing the ECG has put the electrodes in the right place. So usually it shouldn't be a problem because your machine will always give you, which electrode has to be attached to which part. So you will be attaching it to the right arm, right leg, left leg, and then you have a set of precordial leads that go from V1 to V6. But sometimes people make mistakes, and so they can switch different combinations. They can switch right arm to left arm, right arm to right leg, left arm to left leg. All sorts of different combinations are possible. So you should have some clues from the ECG that there has been some switch of the electrodes. And that's important because if you don't pay attention to that, you'll be making a wrong diagnosis when the real diagnosis is just switching of the leads. So there are different ways to do this, but if I start talking about lead switch, I can give you a whole talk on lead switch. So in the interest of giving a more comprehensive talk, I've just summarized different patterns that you can notice on ECG because of switching of the electrodes. The most common switch that we see is the right arm, left arm switch. So if you switch right arm and left arm, AVR and AVL are going to switch. So what happens is, when I showed you a normal one, I showed you that AVL is positive and AVR is negative. So in these patients, because you switch them, AVR becomes positive. So if you read any ECG and the first thing you notice is that the AVR is positive, either the patient has significant disease in the heart or they have switched the electrodes. And so then you look at lead 1 will also be switched because lead 1 is a lead that goes from the left arm to the right arm. If you switch the orientation, lead 1 is going to reverse in direction. So if the lead 1 becomes negative, AVR becomes positive, AVL becomes negative, instead of making a diagnosis of some abnormality, you should highly suspect that there's been reversal of right arm, left arm leads. Similarly, you can have left leg, right arm lead reversal. Here, AVF and AVR will switch places. So the clues to these would be looking at an old ECG of the patient. And if things have changed in these particular leads, then you think about these switches. If you have a left arm, left lead switch, you again would have to look at the vector configuration of the AVL and AVF and how they look like earlier and how do they look like now. If you reverse, the right leg lead is a grounding lead. Okay, so if they switch right leg lead to right arm or left arm, that is very easy to diagnose because one of the leads then becomes flat. Okay, and so that is very easy. If you switch right arm with the right leg with left arm, then lead 3, which was supposed to be a lead between left leg left arm and left leg is now going between right leg and left leg, and so there is no vector there, so it becomes flat. Similarly, if you see no voltage in lead 2, you should suspect right leg, right arm reversal. Okay, so if right leg is reversed with any of these things, it's very easy to diagnose. You just get a flat signal in lead 3 or lead 2. Now, if you look at precordial leads, they are placed in the V1 is placed on the right side of the chest. Then you start V2, V3, V4, V5, and V6 on the left side. And you start from the intercostal spaces and you go down. So this is the normal pattern of activation of V1 to V6 in a patient who has a normal heart. So V1 looks more like small r with the big QRS. And the R wave slowly grows as you go from V1 to V6. Because as you start going more towards the left ventricle, which is where most of the voltage is. If you were to switch, if you see that the pattern changes, then you should think of reversal. For example, if you look in the patient below, V1, V2, R wave is slowly growing. Suddenly it becomes very big in V5, and then again it becomes small in V4, and then V5 that is marked is even worse, more smaller, then it's big. Then you know that what kind of switch has happened. So this is relatively easier to pick up. You will just see that the pattern, which is supposed to be following one particular pattern, has changed. Now, sometimes patients have right ventricular hypertrophy where they will have bigger voltages here, but still the transition should be occurring smoothly rather than abrupt change in one lead. Anytime you see an abrupt change in one lead and then it reverses in the other leads, you know there has been a switch in the precordial leads. Now, one important distinction that you have to make is between whether the patient has a right arm, left arm switch or the patient has dextrocardia. So dextrocardia means the heart is located on the right side of the chest instead of the left side of the chest. So if that happens, in that also, there will be a atypical pattern in AVR and lead 1. So I told you that if AVR becomes positive and lead 1 becomes negative, you should think of lead switch. So how do you know whether it's a lead switch versus dextrocardia? Because both of them will give you the same pattern in AVR and lead 1. And the important thing is looking at the precordial leads. Because now, in this normal heart position, if you look at the precordial leads, which were V1, V2, V3, V4, V5, V6, the R waves were slowly growing as you were going across. Whereas if the heart has then moved over here, what will happen is, as you go from now V1, V2, V3, V4, V5, V6 are here, but the heart is lying over here. So most of the voltage is going to be in V1 and V2. And as you keep going down, the voltage will be going in the other direction. So if you see a reversal of voltage pattern in V1 to V6, along with that atypical pattern in AVR and lead 1, you should think of dextrocardia. Whereas if you see a normal voltage pattern in V1 to V6, but AVR and lead 1 are reversed, then you know it's a lead switch. So this is an example that's showing you where lead 1 and AVR have reversed. And the precordial pattern is still the same as you would expect. And so then this would not be dextrocardia. This would be a lead switch. Now, since you can see the atrial activation designated by the Pwaves, you can try to diagnose structural abnormalities in the heart based on the morphology of the Pwaves. So if you see that the P wave is very tall, especially in lead 2, then you think of right atrial abnormality, because right atrial abnormality will cause increase in the height of the P wave. If you see the P wave is very wide in lead 2, then you think of left atrial abnormality. And again, in V1, the initial part of the P wave is the right atrial, the latter part is the left atrial. So if you have a left atrial enlargement, you will see a significant second component, which is big in V1. And in lead 2, you will see a broad duration of the P wave, which is called P mitral, because it's one of the reasons you see left atrial abnormality is in patients who have mitral stenosis. P pulmonale would be seen in patients who have pulmonary hypertension and have a right atrial enlargement, or patients who have COPD, they can have that. Now, the electrical activation of the heart, as you can see in the cartoon over here, it starts from a structure called the sinus node, which is where all electricity from the heart starts. And then that spreads to activate both the upper chambers of the heart, which is the right atrium and the left atrium. Then the conduction goes from interatrial through to the AV node. There are different inputs to the AV node from the atrium. And the AV node acts like a filter, and then it conducts through the AV node, through the bundle of His, to the left bundle and the right bundle to activate the left and right ventricles. So this is a pattern of normal conduction that you notice that is present in everybody. You can have problems of the sinus node. So the sinus node can, if it is normal, we call it normal sinus rhythm. If there is variation in the P to P interval, we call it sinus arrhythmia. If the sinus load is beating too slow, so the normal sinus rate is generally thought to be between 60 to 100 beats a minute. So if it is less than 60 beats a minute, it's referred to as sinus bradycardia. If it is faster than 100 beats a minute, we call it sinus tachycardia. If there is no sinus activity, we call it sinus pause or arrest. And there are different versions of this. They are classified as sinoatrial exit blocks, which I'll show you how to diagnose. So the normal rate of the P waves is 60 to 100 beats a minute. And you can calculate that on a regular 12-lead ECG based on the duration. As I told you, if it's in a 25 millimeter speed, this one small box is 40 milliseconds. So 40, 80, 120, 160, 2. So you know that is 2 milliseconds. So you can go from here to here and calculate this, and you can come up with the heart rate. If it is between 60 and 100, it's a normal heart rate, what we call sinus rhythm, normal sinus rhythm. Then the other thing we look at is the P to P interval. Is it pretty constant, or there is significant variation? Now, there might be some little bit of variation when you record the heart rate, because it's not always the same. We have different inputs going to the heart from the sympathetic system, from the parasympathetic system. But if you notice that there is significant variation in the P to P time, then we usually refer to it as sinus arrhythmia. If the sinus rate is beating too fast, more than 100 beats a minute, call it sinus tachycardia. If you were to start exercising, or you were suddenly excited, or you were afraid or something, then anything that causes increase in sympathetic tone to the heart will increase the heart rate, and you will have sinus tachycardia. If the sinus rate is very slow, then you call it less than 60 beats a minute, is sinus bradycardia. Sinus pause or arrest means that you have normal sinus rhythm going on, and then suddenly you have no sinus activity, which means you don't see P waves. And so if you see a pause where you don't see P waves, then we refer to as sinus pause or sinus arrest. If the P to P interval, if this pause is some multiple of the previous P to P interval, then we refer to it as sinus exit block type 2. If it is not a multiple of that, then it's called sinus exit block type 1. If you don't remember exit blocks, you can just think of it easily as a sinus pause. And different variations depend on what the interval is as compared to the P2P interval that started it. So this is showing you an example of second degree type 2 or type 2 sinus exit block. So basically, as I told you earlier, here the P2P interval was 1080 milliseconds and the pause was twice 1080 milliseconds. So you know that this is type 2 exit block. And the pause is not a multiple of that interval, then it's a type 1. Type 1 means there is slowing of conduction. So you see sinus conduction is slowing, and then it blocks. Whereas over here, it's the same, and then suddenly there is a block. And this pattern that is called type 2 exit block. This is called type 1 exit block. And we'll see the same kind of blocks when we look at conduction in the AV node. AV node conduction is a little bit easier to understand as opposed to the sinus pauses. So what are the different abnormal rhythms you can get with atrium? So this is in terms of faster rhythms. So you can get extra beats coming from other parts of the atrium. So not necessarily the sinus node, but other parts of the atrium can also beat. So when you get that, we call it APC or PAC, which is premature atrial contraction. Okay. It can come from the right atrium, it can come from the left atrium. You can look at the morphology of the P wave and you can pretty much predict where it's coming from. So one simple rule for us when we see an extra beat or premature atrial contraction is we look at V1. In V1, I told you the first part of V1 is because of activation of the right atrium, and the second part is activation of the left atrium. Left atrium is very posterior, right atrium is very anterior. So V1 is lying here. If you have extra beats coming from the posterior, the back of the heart, V1 is very anterior. So they will be going towards V1. So if you look at those extra beats, V1 will be positive, or terminally it will always be positive. So if you see a very positive extra beat with a positive component in V1, you should think of it as coming from the left atrium. Whereas right atrium is an anterior structure and V1 is an anterior lead. So if it comes from the right atrium, it will be going away from V1. So here, if you look at V1, it will be a negative P wave in V1. So that's the simple rule of differentiating right atrial extra beat from left atrial extra beat. And again, we will use the same rule when we look at right and left bundle branch block. So you can have these extra beats coming from the atrium, which are called PACs or APCs. You can have sustained fast rhythm from here, which is called atrial tachycardia, which can be coming from one place or different places. So that is called multifocal versus simple atrial tachycardia. Or you can have other fast rhythms which are labeled atrial flutter, atrial fibrillation. And I'll show you more examples of that with cartoons so you can understand them very well. So this is a classification of fast rhythms coming from the upper chamber of the heart. So it is referred to as supraventricular tachycardia. So all of the fast rhythms coming from the upper part will be classified under this. So if you look at the broad classification, the one diagnosis that is predominant would be atrial fibrillation. And there is a category called paroxysmal supraventricular tachycardia. Now this is more than anything else, but this is not one tachycardia. This is a combination of different tachycardias. So if somebody tells you what is the number one cause of fast rate coming from the upper chamber of the heart, then you're going to say it is atrial fibrillation. Then the number two would be atrial flutter. Then the other would be multifocal atrial tachycardia. PSVT is a rhythm disorder which is characterized by paroxysms of very fast regular tachycardia, and they include AV node reentry tachycardia, AV reentry tachycardia, and atrial tachycardia. Again, we'll go to the next slide and see what they mean. Okay. So this is 12 lead ECG in a patient, and you have all the 12 leads: lead 1, lead 2, lead 3, the augmented limb leads, and the precordial leads. You can see that the heart rate is fast. So it's close to about 150 beats a minute, because one big box is about 300, two would be 150. So it's between 150 and 200. So that's the fast rate. And you can see that the QRS complex is narrow, so which means it's going through the conduction system. So this would be referred to as supraventricular tachycardia. This is an example of what we call AV node reentry tachycardia in supraventricular tachycardia. And let me show you what that means. So the AV node was a conducting tissue between the atrium and the ventricle. Some patients have two ways to go down the AV node. One is called the slow pathway, one is called the fast pathway. In these patients, they suddenly go down the slow pathway and they come back up the fast pathway. So normal conduction is going through fast pathways. They get an extra beat that blocks in the fast pathway, goes down the slow pathway, and now the fast pathway is ready to conduct back, and they can come back up the fast pathway, and then that is the kind of tachycardia they go in. When this happens, we refer to it as AV node reentry tachycardia. And there is a particular way of picking this up, and that is by looking at the ECG. If you compare this to the old ECG, you get a pattern in AV1 where you see a pseudo R prime pattern. But towards the end of the QRS complex, you see a small R wave, which is called pseudo R in V1. And in the inferior leads, you see that correlates with what we call S wave. So we call it a pseudo S wave. If you compare in sinus rhythm, this patient will not have that in sinus rhythm. If you see this pattern, pseudo R or pseudo S wave in tachycardia, which you don't see in sinus rhythm, you should think of AV node reentry tachycardia. This is the second most common cause of PSVT, which you are seeing in this slide. Here you see P wave followed by a short PR interval. So see P wave and a QRS complex. So this is less than 120 milliseconds. So that, and you see sort of a P wave, you see what we call a delta wave, and then you see a wider QRS. When you see these three things, short PR, delta wave, wide QRS, we call it WPW syndrome or Wolff-Parkinson-White syndrome. If you see that, then you should suspect that most of the fast rhythms in these patients are coming from this disease called Wolff-Parkinson-White syndrome. But you have to suspect it and pick it up on an ECG. And the way to do that is to look for a short PR interval, a delta wave, and then a wide QRS. And so these patients can also go into a fast rhythm, which has a narrow complex, supraventricular tachycardia, and it's regular. However, in these patients, instead of having a pseudo S wave or a pseudo R wave, they have more of what we call short RP tachycardia, or the P waves are a little bit away from the QRS complex. And it usually manifests as if they are having ST depression during tachycardia. You can see that this is the baseline, so the ST segment has gone down. And whenever you see that, you should think of a tachycardia involving a WPW pathway. The other way they can go into tachycardia is they can go into wide complex tachycardia, which is then referred to as pre-excited tachycardia, and which means that now they are going down the accessory pathway to activate the ventricle totally through the accessory pathway. So they are very wide. Again, I'll show you a cartoon. And one of the problems is if you don't pick this up right or treat it the wrong way, they can go from this to very fast ventricular tachycardia, and then they can die from that. So you really have to be very careful in these patients. This is a young kid, 16-year-old kid, who presented with atrial fibrillation, and he was going down conducting very fast through this WBW accessory pathway. So this is what happens in these patients. This is a cartoon to show you one location of a WPW. So as I said, in normal sinus rhythm, you have conduction starting from the sinus node, which then spreads through the atrium, through the AV node, down to the ventricles, through the right bundle and the left bundle. In patients with WPW, they are born with an extra muscle connection between the atrium and the ventricle. Now, in this would also be on the left side of the heart. Another way of going down to the ventricle, so that muscle conducts very fast. It does not have the decremental properties of the AV node. So the AV node allows conduction at 120 to 200 milliseconds from here to here. This does not have any such requirement. So this can conduct very fast. So that is why they have a shorter PR interval. They have a delta wave, which is a fusion of conduction from here and the AV node. And then because it goes from here, it can activate the ventricle with a wide complex. So that is why you have the third feature, which is a wide QRS complex. So they can go into tachycardia by going down the conduction system, coming back up the accessory pathway, so which is called orthodromic tachycardia. This would be a narrow complex tachycardia because it's using the conduction system. If they go the other way, which is antidromic tachycardia, which means they go down the accessory pathway and up the AV node, then it becomes wide complex tachycardia. The most common scenario they get is they get atrial fibrillation in the upper part. The upper chamber is beating fast and irregular, and that makes the lower chamber beat fast and irregular through the accessory pathway. The third kind of supraventricular tachycardia, or paroxysmal supraventricular tachycardia, which is regular, is what we call focal atrial tachycardia, which means there is just a focus in right or left atrium, which is beating very fast and just firing by itself. So when you look at PSVT, if you see the P wave right towards the end of the QRS complex, which is the pseudo R wave or the pseudo S wave, you think of AV node reentry. If you see the P wave a little bit after the QRS complex, wherein you see ST depression, you think of WPW with AV reentry tachycardia. If you see a long RP tachycardia, which means the distance between the P wave and the R wave and the next P wave is long, is beyond the T wave, then you think of focal atrial tachycardia as the mechanism. Now, the other causes of supraventricular tachycardia, which are not necessarily regular, are atrial flutter and atrial fibrillation. Atrial flutter, everybody should be able to pick up on the ECG, and this is a classic 12-lead ECG of atrial flutter. And this is what you see is you see these P waves, which have a sawtooth pattern. And you will see a lot more P waves much faster and more. So P waves are going at 300 beats a minute. And usually if these patients are not on any medications, the QRS goes at half the interval of the P wave. This patient is not doing that because he's probably on medications. So if you see somebody going at 150 beats a minute all the time, and you see some kind of a pattern like this in between the QRS complexes, you should give them adenosine or some drug to block the AV node, and then you will be able to see the sawtooth pattern of the P waves. So if you see sawtooth pattern, very fast P waves going like this in the inferior leads, this is an example of classic, typical right atrial flutter. Okay, that you guys should be able to diagnose. And when you see this, you would need to call your cardiologist because the treatment involves a few different things. But this is an arrhythmia that is curable by catheter ablation if you get the right people involved. And this is the circuit of atrial flutter. In atrial flutter, it's a what we call macro reentrant tachycardia. So it's a very big tachycardia. And here, what happens is the circuit is very big. So this is a circuit that goes in the right atrium. It goes around like this in a big loop like this. And so in these patients, you see a sawtooth pattern because this rhythm is going away from the inferior leads. So in 2, 3, and AVF, you see negative P waves, which are going away from 2, 3, and AVF. And they're going towards V1. V1 is right here. So in V1, you will always see positive. If you see very fast P waves, which are negative in the inferior leads, looking like a sawtooth pattern, positive in V1, you should think of it as typical right atrial flutter. And as I told you, the second clue is if the patient is not on drugs, the ventricular rate will be half of the atrial rate, which would be 150 beats a minute. So in patients who have irregular narrow complex tachycardia, which means it's a narrow complex, but it's irregularly irregular, then you think of atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. When it is regular, I told you the three differentials, which was AV node reentry tachycardia, AV reentry, and atrial tachycardia. Now we shift focus to the lower chamber of the heart. If you look at the lower chamber of the heart, then there are two lower chambers, the ventricles. So any rhythm that is coming independently from the ventricles will be called as ventricular premature complex. So if you have extra beats coming from the lower chambers of the heart, they are called PVCs or premature ventricular complexes. If they are organized and very fast, they're together, then it becomes ventricular tachycardia. If it is very, very fast, then we call it ventricular fibrillation. So the difference between these two is just a rate. They're both fast. Tachycardia means fast heartbeat. Ventricular tachycardia means coming from the ventricle. If it's at atrial tachycardia, that means it's coming from the atrium. So this is showing you an example of where a patient has sinus rhythm and then gets a wide complex beat which is not preceded by a P wave. You have a wide complex beat which is not preceded by the P wave. It is referred to as premature ventricular complex. Now, when you get a wide complex beat in the middle of and between a sinus beat, then there are few possibilities. Most likely it is coming from the ventricles, but it is also possible that the wide complex beat is actually coming from the upper chamber of the heart. And why would it be wide? Because when it tries to conduct through the conduction system, it blocks one of the bundles. Either it blocks the right bundle or the left bundle. If it blocks, then the QRS complex will be wide. But that is not necessarily coming from the ventricle. It is actually coming from the atrium in all of these things that I showed you earlier, and just blocking in one of the bundles. So when we see a wide complex beat, we really have to prove whether it is ventricular tachycardia or it is supraventricular tachycardia with a bundle branch block. It's a block. And this is also referred to as aberrancy. Supraventricular tachycardia with aberrancy. So the differential diagnosis of wide complex tachycardia then becomes, number one is always ventricular tachycardia, which means it's coming from the ventricles. Number two is supraventricular tachycardia with aberration or bundle branch block. Number three is pre-excited tachycardia, because I showed you when you had WPW syndrome, you have a tissue that can conduct very fast. And if you see fast, irregular tachycardia, this is usually irregular, very fast, and seen in young patients. If you see a young person coming to the emergency room with wide complex, irregular tachycardia, you should think of WPW. If they are stable, look at their old EKG. If you look at the old EKG, you will see a short PR interval, a delta wave, and a wide QRS. Once you see that, you make a diagnosis that you have WPW, and now what you're seeing is pre-excited tachycardia. The other two things that can cause wide complex is pacemaker-mediated tachycardia. Somebody has a pacemaker in the lower chamber of the heart, it always activates the ventricle with a wide complex. So that tachycardia will be a wide complex tachycardia. And lastly, an important thing to remember, just like people can switch leads, there can be artifact recorded on the ECG. And that can be recorded because the patient is moving, the patient is trembling, patient is having Parkinsonism and has tremors, or there is some noise, electromagnetic noise in nearby, which is being picked up by the 12-lead ECG machine. And so that appears as if the patient is going in wide complex tachycardia, but in real time, what is happening is they have normal sinus rhythm, and the noise is coming in and causing the impression that there is wide complex tachycardia. So you really have to prove this by certain maneuvers. So there are different ways to prove wide complex tachycardia. There are different algorithms. This is one of the criteria that I've given you over here, which is called the AVR criteria. And you have a reference attached to that. So in the interest of time, I won't go into the details of that, but they have a stepwise approach in a patient with wide complex tachycardia that can be used to differentiate it from ventricular tachycardia or supraventricular tachycardia with aberrancy. And so again, I have the reference here, which I would be useful for you to read and to use. The last part is looking at slow rhythms coming from the AV node. So we looked at slow rhythms coming from the sinus node, which were called as sinus pauses. The slow rhythms that come from the AV node can be a very long PR interval, so long conduction time between the atrium and the ventricle, which is more than 200 milliseconds. So if it's just prolonged, we call it first degree AV block. It has to be more than 200 milliseconds. That's the criteria. If it is prolonged and also there is a block between the P wave and the QRS complex, then you have to see whether the block is happening in a regular manner or an irregular manner. If the PR interval is slowly prolonging and then blocking, we call it type 1 second degree AV block or Wenckebach AV block. So there's PR prolongation slowly and then block. That is called Wenckebach. If the PR interval is constant and then there is a block between the upper and lower chambers, that is called type 2 second degree AV block. Type 1 second degree AV block is usually happens in the AV node, is not an indication for a pacemaker. Type 2 happens below the AV node and is an absolute indication for a pacemaker. And then the last thing, you can have complete block between the upper and lower chamber of the heart. So in other words, the upper chamber is beating at a much faster rhythm and the lower chamber is beating at a slower rhythm, which has no relationship with the upper chamber rhythm. So this is called third degree AV block. And that means there are more P waves than the QRS complexes that are going through. This slide, I am just showing you an algorithm, another algorithm to approach patient with wide complex tachycardia, which is again, it is directed at proving dissociation between the atrium and the ventricle. And this would go along with the wide complex tachycardia algorithm that I showed you. Basically, you try to show dissociation between the atrium and ventricle, which means if you show that the atrium is marching slower, then the QRSs are coming from the ventricle. And then there are different criteria based on morphology and in precordial leads, which is the Brugada pattern, Brugada criteria, or right and left bundle branch block morphologies in precordial leads. And then finally, the criteria that I showed you, which is coming from AVR. So this is just showing you an example of what we call AV dissociation, where the P waves are marching slower than the QRS complexes. If you show this in a wide complex tachycardia, you prove that the QRS complexes are coming from the ventricle, and this is ventricular tachycardia. Similarly, if you have a wide complex tachycardia going on and you show a narrow complex beat in the middle of wide complex tachycardia, you again prove that the wide complex is coming from the ventricle, and the narrow complex was just normal beats, sinus beats coming through the AV node and capturing the ventricle, causing it to be narrow.